everyone, we are standing here today with Dr. Nunes. He is a foot and ankle surgeon here at Hyperlife Medical Center. He's going to tell us a bit more about the lateral ankle sprains and the surgery that he does for that. Hi Dr. Nunes, thank you for joining us.
Thanks for having me.
Alright, so why don't you just give us a little bit of a background on the anatomy of the foot and ankle and what ligaments are involved when we talk about a lateral ankle sprain.
Okay, so what's important to realize in the ankle is that there are a lot of complicated joints and ligaments that get the whole thing to work together. And the two most common ligaments that are involved are this big broad ligament over here that's called your talofibular ligament because it joins those two bones. And this fan-shaped one over here, which is called your calcaneofibular ligament, which prevents the ankle from rolling in. What's important to realize is that these two tendons here, which help the foot move outwards and is protective when you have a sprained ankle, often get injured because it's right in that ligament. When this ligament tears, it also injures the tendon. Another ligament that's sometimes involved is this one that holds the fibula onto the tibia. These are the two main bones of the ankle. And that's called a high ankle sprain. These two ligaments are involved in a low ankle sprain. And the way you injure them are differently. This type of ankle sprain is the one that the general person gets. So anybody, you don't have to be an athlete, you can just slip and fall on some loose tiles or with your dog or step in a pothole. This one on the top here is more common in athletes and jumping sports and sports that involve change of direction.
When you have a lateral ankle sprain, obviously you go and see a doctor and then they will tell you whether it's a grade 1 or grade 2 or grade 3. At what point do you actually operate on the ankle and fix those ligaments? And at what point do we do rehab or PRP treatments and physio and stuff like that?
So essentially what's important to realize is that most of the ankle sprains don't actually need surgery. It all really comes down to having a rehab team that knows how to treat this injury and also the severity of the injury. So when it is labeled as a grade 1 sprain, that just means that these structures here have been stretched, but they're still intact. So there's inflammation and your ankle will feel sore and it'll be painful to walk on, but overall the integrity of the ankle is maintained. A grade 2 means that there's a partial tear. So if we had to take a ligament like this, maybe half of the tendon is torn. The symptoms will pretty much feel the same, and a grade 1 and a grade 2 is often treated conservatively. What I mean by that is that we just need to hold the ankle in its normal position and prevent any more sprains, which will increase those tears or increase the grade of the injury. And that's when the rehab team comes into play. Right in the beginning, it's good to go and see a physiotherapist because when a joint is painful and you can't really work with it, that's where the physiotherapist comes in. And they kind of get the swelling down, they deal with the pain, and they get normal movement. Rehab doesn't stop there though, because once you no longer have pain, you then have weaknesses, and these tendons here on the side, they switch off, and that's what protects the ankle from future sprains. That's where biokineticist then comes in, because most of the patients we see at this practice are playing sports in one form or another and at different levels. And once the pain is gone, you need to rehabilitate the muscle so that you can get your balance right and you can get the strength standing on one leg. And that's where a physio and a biokineticist is very important. Sometimes, in rare occasions, you might need to see an orthotist or a podiatrist to have inserts made for your sports shoes, but that's kind of taken on a day-by-day basis and depending on how your rehab goes. When it is a grade 3, that means that everything is torn, and some of these you can get away with without any surgery, but the majority of these require some form of surgery. The surgery that I perform is called a Brostrom plication, and essentially what that means is these paper-thin ligaments, they're not a thick rope-like structure. So if the scar tissue in conservative treatment doesn't help with sticking it down and giving you stability, then I need to take the stretched scar tissue that's there and I need to tighten it up. And what that requires is an incision along this fibular bone, exactly where these two ligaments attach. I draw some holes, and the loose tissue I pull up and I tighten onto this bone and I hold with the anchors. And that essentially maintains your anatomy and your biomechanics And the recovery from this is pretty straightforward. You'll essentially be in a cast for 4 weeks, at which point that comes off and you go into a brace. That's when you start your physiotherapy. That normally lasts about 4 weeks, and then you go and you see a biokineticist afterwards, where they then compare it to the good side, and once those two are within 10% strength of each other, you're then cleared for all sorts of sport.
Can you quickly just show us some of the tests that you do when you assess a lateral ankle sprain?
Sure. So this is Taylor's feet.
Ah!
So the first test that I'll be demonstrating is called the anterior draw test, and that's to stress test that ligament that goes from the fibula to the talus, and it's quite high up here. This is often where you feel the pain. So what that requires me to do is I need to stabilize the ankle joint, okay, up in its maximum position, and then I'm going to pull it forward, and you can see there's no movement there. If it was torn, relax the foot, then you'd get that sort of stretch, but it's only stretching like that because I haven't locked the ankle. So only in this position are you actually testing that anterior talofibular ligament. The next one is your calcaneofibular ligament, and remember that those peroneal tendons attach there, and it runs right through the ligament, and that prevents this sort of movement. So the same sort of concept, we're going to go down, grab the heel, and we stress it, and there's a firm end point there. If there's a rupture, this continues going all the way across. And the last test that we generally do is to test the syndesmosis. So what happens there is the ligaments that join this fibular bone to the tibia splay. So what I'm trying to do is I'm trying to see if I can gap this bone across. So stabilize the calf, and then we go to the side. And you can see there's a firm end point there. If it's loose, this will just carry on going, and the patient will complain of pain in the front.
So you will do these tests to get a feel and an idea of how badly the ligaments are injured.
Yes.
Will you do an MRI scan then, or how do you go from there?
Essentially it depends. If there's ankle pain on the inside, then I'm going to be a bit more worried that there's a cartilage injury, and in those cases and in chronic instabilities I'll probably ask for an MRI scan. But if it's an acute injury, these cannot be performed in the first 2 weeks because it's too painful for me to be able to stress them. So usually that's where you rest it and you splint it, and you do Rice protocol. Then you'll come in and I'll stress test it then. If clinically they are lax, then there's no real reason to investigate further unless I'm suspecting another injury in conjunction with it, like I said, the cartilage and the tendons.
Do you think it's a good idea to brace or not, and what is your reasons?
So absolutely a good idea to brace. That as soon as you've sprained your ankle, you should go into a brace. A moon boot is too restrictive for this. So a moon boot is a bad idea because you're not actually stabilizing the ankle joint in its normal position. You want up-down movement, you just want to prevent the rolling action of the foot. So the brace that I like to use as first line is called an ankle stirrup. It's 2 hard pieces on each side, much like a horse stirrup. If you don't have one of those available, then a speed sock is also adequate, but it doesn't really allow up-down movement as well as a U-brace. But a moon boot is only really used if you've got a grade 3 injury and if you've got associated fractures, because sometimes you can have fractures with this. But essentially bracing straight away and then Rice protocol.
Okay. What we see over here is that people have minor sprains and they have a couple of them, and eventually they end up with quite hectic instability in the ankle because they've never rehabbed it properly or they've never gone to a doctor for an opinion. So if a person has an injury initially and they go and have it treated, does it prevent them from getting chronic instability in the ankle or having that ligaments re-injured?
So again, it would come down to what the patient is presenting with. So in a straightforward case where a patient's had multiple sprains but has never had rehab, I always recommend that the patient start the rehab from scratch and you do a full cycle to see if you can in fact train the muscles to stabilize the ankle even though you've got a chronic instability. Obviously it depends on the level of the patient, and what I mean by that is, does the patient play a lot of sports or is the patient working in an environment where there's uneven surfaces? Those patients I will tend to offer the surgery to first because they don't have time or they don't have the sort of physiological capacity to recover from that given the demands of their day-to-day life. But in general, always good to start with the rehab first anyway. Not everybody that has an ankle sprain will progress onto a chronic instability. But when you do have a chronic instability, it's quite debilitating, because even just missing a step or standing on an incline will throw the ankle out.
Yeah.
And the risk with repeat injuries is that you damage the cartilage in the ankle, because every time the ankle pivots out of its socket, you're knocking off pieces of cartilage, and then that will lead to arthritis. And surgeries for arthritis in a young patient are very limited, and they become a problem with your day-to-day activities. So always start rehab first. If that fails, onto surgery. And if you're a high demand patient, then we go straight to surgery straight away.
Okay, awesome. Thank you.
Okay.